if things don't make sense, just interrupt me and ask questions at any time you want to. Like Sudha said, I'm originally from the Netherlands, spent most of my time at UVA. I did a lot of research initially in laboratory work, and then after my temporary stint back in the Netherlands as chair, when I returned to UVA, I kind of switched over to clinical studies, mostly driven by the lab stuff we'd done before, now putting it into practice. And that was all great and really enjoyable. And then, by some random events that I won't spend time on, I suddenly got myself involved in global health work. And I started doing teaching in East Africa, first in Tanzania and in Malawi. And then in 2011, I got suddenly, unexpectedly again connected to Rwanda for the first time. And this was because of, here, let me make sure that this works. Yes. Because of a new program that was about to start there, this Human Resources for Health project. So this was officially launched in 2012, but in 2011, the initial meetings held place, and UVA was part of that. And just because I'd happened to be working in some countries around that area, I got asked to participate for the anesthesiology part. So HRH was a really, really interesting program. It was initially kind of envisioned by Rwanda as part of its development, because they didn't have enough health professionals, right? So they had 0.7 per thousand, and the recommended minimum is 2.3. So they were off by a factor of 3, and they wanted to do something about this. And the problem, as they correctly realized, was that there were insufficient trainers. There's this terrible vicious circle where if you have very few clinical providers that are overloaded to do all the clinical surgery and anesthesia and what have you, they don't have time to train the next generation of people. And so they cannot kind of work themselves out of that hole. And it's a huge problem that exists in lots of places. So Rwanda basically wanted a cadre of dedicated trainers for a substantial amount of time that would allow them to train the whole next generation of clinicians so that the system could grow to the point where they would have enough people to train themselves. And they managed this in a very substantial way that hasn't really been replicated anywhere else since. Money came from PEPFAR and from the CDC, manipulated and sent it off to Rwanda, and then later from the Global Fund with a budget of about $150 million. So it was a very substantial program. The way in which it worked was interesting, subject to a lot of debate, but it worked. Basically, what happened is they partnered with about 15 universities in the US. And then those universities would send teaching faculty who would stay in country for anywhere between 2 and 12 months. Typically, the longer durations, but for subspecialties, they would accept people going shorter. Now, those were typically not their own faculty that went. Anybody could apply, anyone with the right credentials. You would then get a temporary appointment at the university and be sent out as a member of that university. So we would hire, UVA participated for anesthesia and surgery, and we would hire people from around the world, literally, who had then a temporary UVA appointment and then went off to Rwanda for their duration. So different universities took different roles. Some specialties were handled by multiple institutions. So anesthesiology, for example, was handled by UVA, Harvard, and Dartmouth in close collaboration. There was a lot of logistics involved in all of this. Initially, the Clinton Foundation ran this, and then it was transferred to the Rwanda Ministry of Health. And the funds flow was, how best to put it, painful and potentially problematic. The money came from the US, basically, but it was all transferred to the Rwanda government. And the government then reimbursed the US institution that were taking part. It's a bit of a complication there. It cost me a lot of nightmares and gray hair because it wasn't always the quickest process. And, we were paying those people. We sent about 20 people over the course of the program, mostly staying for half a year to a year. We were paying those people salaries from our departmental funds, and then had to wait for money from Rwanda to get back to the institution. And there was one point where the Rwanda government was more than $1 million in debt to the Department of Anesthesiology at the University of Virginia. And I could only really be happy that most of my colleagues were not even aware that this program was running at our institution, because they would not have been happy about this. But it worked, okay? Now, for anesthesiology, it was actually a fairly easy job because, as Sudha pointed out, there was already an existing program. So these are a couple of horrible acronyms. CASIAF is the Canadian Anesthesiology Society International Education Foundation, and ASAGHO is the American Society of Anesthesiologists Global Humanitarian Outreach Committee. Forgive me that letter jumble, but they work together to provide training capacity to Rwanda. And that program has existed since about 2006, and it worked like a charm. And I don't really believe that I've ever seen anything duplicated with quite the effectiveness and the success rate. The model was simple. They sent a volunteer every single month, a faculty member, to teach for a month. So there was a full-time faculty FTE there with nothing else but teach. And that person typically was from a university, typically came with one or two senior residents. So as a result, there typically were 2 or 3 people with nothing to do but teach. As a result, they could take in some additional residents and started growing out of that big hole they were in, because their hole for anesthesiology was very, very big. And after the genocide, there were about 2 anesthesiologists left in the country. That was the situation in 2006 when this program started. By 2018, when we're getting close to the end of HRH, there, Human Resources for Health, there were 20. And by now, the group was large enough that it could sustain itself. And currently, we're up to about 40, which is still not at all where they need to be, but it's made immense improvements over time. So with Human Resources for Health coming into place, there was a kind of natural synergy between these 2 places. I was in my role as a coordinator for the HRH program, but I also started doing clinical teaching with anesthesiology over for CASIEF, if only to just understand how the system works. HRH worked really, really well. It had a lot of very painful and difficult moments, as you can anticipate from something this big. It was huge, right? It supported 22 training programs, so that was pretty much all the medical specialties, some of which, like 12, were not in existence. Like emergency medicine did not exist as a specialty in Rwanda when HRH started, and some very courageous folks just created a whole residency program from scratch. Wholly different from the situation with anesthesiology, where we just had to jump in and make some few adjustments. It ran on about 100 visiting faculty per year until about 5 years into the program, when the first graduates were coming out of these residency programs, and they could slowly reduce the number of foreign faculty, which were then being replaced by the graduated Rwanda people. And by the end of 2019, when the program was intended to shut down and did so, there were more than 4,500 graduates trained. So it was a really, really successful program. But in part, it was successful because it did exactly what it was intended to do, and that is train clinical people. And that left it with a number of gaps that were realized mostly, but that were specifically not filled because they couldn't. So one of those was that there was now this large group of thousands of new faculty in Rwanda, because almost all these people stayed at the universities, who were quite well trained clinically, but had no experience whatsoever in being an academic person. They knew very little about teaching by and large, and nothing about research. The teaching varied by specialty. Again, we were very lucky in that this CASIEF training program had already incorporated learning how to teach into their program. And residents in their final year did actually most of the teaching for the CASIEF program already. But in other situations, other specialties, that wasn't the case. And so they had a hard time learning how to suddenly be teachers. And for research, it was even worse. And, you don't have to all be doing, major clinical trials, but you need to have some degree of, facility with the research process in order to function as an academic faculty member, if only just to be able to read and interpret papers. And that was not part of HRH, okay, in most of the settings. So I had done a lot of thinking. A lot of my background was in research, and I'd been doing a lot of thinking before that about that. And so we decided a little bit before HRH was to end to, in anesthesiology, address it by providing a research course. So this was a thing called the Acute Care Operational Research Course, or ACORE, which was geared to a bunch of specialties that you see listed here that are, related in some way by taking care of acutely ill patients. And we built a course that was largely done remotely, but with some in-country work to provide a basic form of research training. Now, there was absolutely nothing new about this as a principle. There's something called a sorted course. That stands, another horrible acronym, A little bit better than CASIEF, but still. That's the Structured Operational Research Training Initiative, which is now run by the World Health Organization. And they run courses in specific locations to train people in operational research. And I won't go into details, but it's basically a very practical, locally applicable type of clinical research that is really, really important, particularly for low middle income countries. Just to give you one example of why it's important, it's because most of the clinical trials that show you that a particular treatment, like a drug or what have you, can work, are done in high income countries. And let's take a simple example, as you say, beta blockers for secondary prevention after heart attack or something like that. Well, you have no idea if this actually will work in a place like Rwanda, where the disease processes that patients have are different. Their genetics are different. Their diet is completely different. The intervention that are available are different. And so lots and lots of these kind of standard protocols actually really, really need to be reevaluated on those specific populations in those settings. That's what operational research is very good at. All right, we modified the sorted course. Again, we were one of several groups that were working on this. The sorted had as a big disadvantage that people had to fly to Ethiopia, for example, from East Africa to take it. So they already had helped by recording most of their lectures, putting them online. We could essentially build this course as largely remote with people working by themselves. And then we shifted the focus, which was strongly on infectious disease, to the more surgical and intensive care kind of setting. It worked really well. It was great fun to do, to see people who knew nothing about research to come in with a clinical question they have and kind of see them develop over the course of a year to writing a research protocol, dealing with the IRB process, thinking about how you're going to analyze the data, collecting the data, etc. And one thing that we could put in there as well is to let our students from Virginia participate. So these young faculty members are still very busy clinically, and they don't have much time to go collect data. So we could help them by sending students, mostly medical students, but also undergraduates, to Rwanda for a period of 6 weeks or so, funded by our university, who basically would just help collect all the data for the trial during that time period. A lot of these studies are based on archived records, and so that's a boring but a very doable job. You can collect a lot, but we had a fair amount of clinical data collection as well. And then they could help some selected students with the experience with data analysis at the end. So all this worked great until 2 years later, after we got started, COVID came along. So the first year was perfect, and the second year crashed halfway through because they shut down the hospitals. You could only get in there for clinical activities in Rwanda, and there was such an increased clinical load suddenly that these young faculty members didn't have time to do it. And that was very unfortunate. I mean, it was a good program. They tried again a year later with a smaller group. It again, COVID was still highly active, and it again didn't work. And we have not restarted it since that time. It's still a great program. I still, it would be worthwhile. There's several other kind of implementations in other countries. And if somebody is interested in the model per se and the materials, I'll be very happy to talk and share that. But all of this had made me think even more, and we had shown that you could do something as complicated as a research course in essentially completely remotely. There was an in-person part at the end to help write the paper, but that was helpful, but not absolutely necessary. And the question arose, how many more things could you do remotely that we kind of, as a routine, would just get on a plane and fly to do. Now, just about this time, and this is kind of how those things tend to get together, we got a new president at the university, Jim Ryan, great guy. And so there was a new strategic plan a while later. And in that plan was written, which is quite interesting, this statement: we will enable our undergraduate students to develop the knowledge, perspective, experience, and skills necessary to lead in a globally connected world by providing them with an opportunity to have at least one international experience before they graduate. Now, I have a lot of problems with this statement. I think it is excessively optimistic to think that one international experience would allow somebody to lead in the globally connected world. But this is where they were. The other problem is that it's it's ambitious in the way of, just pure numbers. That this would mean 4,000 students going somewhere every single year from UVA. That's a lot of cost. It's a lot of carbon. It's also not necessarily equitable, right? The university will pay for a lot of this kind of things, but there's still costs to be borne by the students themselves. And then it depends a lot whether you have that money available or whether you are one of the poorer groups, you cannot do that. So there's a certain kind of built-in inequity. And as a result, the questions kind of coalesced and said, well, would it be possible to make this international experience a remote one, right? Now, remember, this was all before COVID hit, right? I mean, things became focused quite a bit about doing things remotely like we see today with COVID, but this was like in 19 when this happened. Now, it also happened that, again, another initiative of the new president, there was a new granting mechanism at the UVA, which was for institutionally related research. So they gave fairly substantial amounts of money for research activities that would help improve life for students and faculty and everybody at the university. So I got a couple of people together and we applied for one of those grants saying, look, we're going to see if a remote experience would be considered equivalent to a actual in-person travel experience to help you with this promise that every student will have an international experience before graduation. A lot of it was focused on the CO2 generation because that's, it's very large. And I think most students and maybe even some of the people who wrote this were not completely aware of it. This is kind of an interesting graph. It's from The Guardian from a couple of years ago. And basically it showed you return flights between various countries, London, Rome, right? Very, very close together, just from here to there. One round trip flight generates more CO2 than citizens in any of those orange countries generate in a year, okay? And obviously, if you go further away, that amount of orange becomes bigger. And if you fly London, Los Angeles, which is pretty far, it increases even more. Now, if I stick one of my routine flights to Rwanda on this, and I just calculated this out, I come to about 1,500 kilograms of CO2 for the round trip from Washington to Kigali, again, which is roughly this range, about the amount of CO2 than any citizen in any of these orange countries generate in a year. Now think of 4,000 students flying every year from UVA. That would be a pretty substantial increase in carbon footprint for the university, which they, may not want to take on in a time when in fact they're actively trying to reduce it. So we got the grant, and this was step one of what was called eGlobal. Okay, it was funded, as I said, by this new Presidents and Provost Fund. It was a big thank you and help from our Center for Global Health Equity at the university, and it was a collaboration between University of Virginia and University of Global Health Equity in Rwanda. And I'll take you to kind of the 3 steps that this process has gone through since that time. So step one was clearly a research study. Okay, so this is literally copied from our application, what we were going to do. The project will compare the effects of international engagement through a traditional travel program to Rwanda, already in existence. This was sending people to ACOR and other kind of activities, mostly to do participate in research project, with an experimental virtual international engagement, which will connect UVA students with international counterparts for long-term engagement through electronic means. And we hypothesized that partnering UVA students with counterparts in this way would result in increased contact time with global peers compared to short-term on-site work. This is maybe not what people think of right away, but think about it. So you go for 6 weeks as a student to help with research. The amount of time you actually spend with Rwanda peers during that time is actually not that great, right? You spend a lot of the time by yourself doing things. Whereas if you do a academic year-long regular interaction, you probably crank up more hours that way than you otherwise would. And we also hypothesized non-inferior cultural learning. This was tested by taking cultural capacity tests before and after in all the groups, and non-inferior experience ratings by the students themselves. Now, as I said, our partner is the University of Global Health Equity. This is a relatively new university in the north of Rwanda that some of you may be familiar with. It's created in collaboration with Partners in Health, and it's absolutely great place. And they set it up, in what is one of the poorest areas and least healthcare served areas of an already extremely poor country. And they did it on purpose because they felt the help was needed more over there. They have a group of exceedingly dedicated and enthusiastic students that were initially in a Master of Healthcare Delivery program, and now then a medical school, and now a nursing school is being added. Their model is very interesting as far as financing goes, because the whole education is free, 100%, including room and board and all the supplies and everything. But they require that everybody who enrolls in the program, and it's very competitive, commits to the same amount of time after the program working for disadvantaged population in their own home country. So this is not a Rwanda-focused university. They did during the first few years, but essentially anybody can apply now. But if, say, you apply from the US and you go to work there, you commit yourself to working in the US with underprivileged groups for the 6 years that this program takes. And you need a signed contract from your government to show that they will hold you accountable for that. But it means that even people without any income can still get their medical school master's education as if they wish. So this then was the team that put the initial eGlobal study together. So at the UVA side, we had myself, we had Tracy Kelly from the School of Nursing here, who was absolutely instrumental in bringing it together, and Rebecca Dillingham, who led at that time our Center for Global Health Equity. She's from infectious disease. And then at the UGHE side in Rwanda, we had Abebe Bekele, who's the dean of the medical school there, and Agnes Byongwao, who was the former Minister of Health from Rwanda, and then had taken on a position as Vice Chancellor at this university. And then we were going to send students. So one group was 20 UVA students who would travel to Rwanda for 6 weeks, participating in clinical research projects in the ACOR research training program, as usual. And then there was, at the same time, going to be 30 UVA and 30 UGHE students put together in groups of 4. And I'll talk a little more about how we do that operationally, working on small projects during the whole academic year over the internet. All right, well, this is where we stood with funding secured and the whole plan in place and everything ready to go when COVID broke. And so we could do part 2, we could not do part 1. There was no student travel. Part 2 group 2 worked great. I mean, in fact, group 2 was one of the very few global health activities that was still in operation at University of Virginia during the pandemic, because it was all remote and they could keep working with their students in Rwanda. In Rwanda at UGHE, they basically locked down the whole University of Global Health Equity. The students stayed on campus all the time and didn't get out. And that's how they continued teaching through that whole time. And in fact, these weekly interactions with students from UVA was, for many of the people there, a really kind of high point of their week. But it totally messed up our research study because we didn't have our control group anymore, right? And the next year, it didn't happen again because COVID was still ongoing. And it was probably about a year and a half ago that we could have done it again when everything was in place. But by that time, so much time had passed. And as a result of COVID, a lot of things had changed, that after a lot of discussion, we said, we can't do that. It's not going to be a reasonable comparison group anymore. And so, with pain in our hearts, we had to drop one arm of the study. We published a paper, which I'll show you in just a second, and left it at that. So the students all that worked remotely all had a project that they could work on, or they could find one themselves, which very few did. The projects were very carefully thought out, because what we wanted them to do is work on something where both sides could learn something. We didn't want a project on malaria in Rwanda, because the Rwanda people wouldn't learn a whole lot, and they certainly wouldn't learn anything about the US. So each of the projects was built so that both sides could learn something from it. So here's one example. You don't have to read through this whole thing, but this is on the opioid crisis. So we obviously have an opioid crisis, but low middle income have a different type of opioid crisis, where because of inability to synthesize their own opioids, they have to import them, and there are very draconian and problematic import restrictions. And as a result, they don't have enough pain medications for their cancer patients, for example. So we would, for each of these little projects, provide a little bit of background and then a bunch of questions, which you can see here, that the students could use as a starting point. Okay, they could start thinking about that, kind of focus in, see what interested them, and then work that out. It was explicitly not the goal to go collect new data, which would not really have been possible during that time frame. All right, so the paper got written and published, and I will happily admit that this is definitely not one of the top papers that I've ever published, but it did show that at the very least that the groups that participated, the students that were in this, were incredibly enthusiastic about it. They really, really liked this interaction. And this kind of brought us to a quandary, because now the study was over, but we had at UVA a list of people, of students, who would have wanted to be in the program but couldn't be. And in Rwanda, the next year of students had appeared, and they heard about what their predecessors had done the year before, and they wanted to be part of this as well. The other thing that we had done, which was nice but has not been repeated, and I'll explain why, is we published all the reports on these little research studies that the students did. We have a kind of with variable frequency published global health journal at UVA called Conflux, and they were nice enough to offer to make a special issue. It was quite a big issue. It's almost a book, just for eGlobal, where all the brief reports that the students had written were published. This was great, particularly for the people from Rwanda who could now, rightly say that they had a publication in the US, which was really, really nice for them. Okay, so that was the research study. Didn't quite go the way I had expected it to go because COVID interfered, but still it was helpful in the sense that, we did realize that this is something that student could be very happy doing, that it was not always the case that they wanted to get on a plane and fly somewhere. So there was requests from Rwanda, and there were requests from students at UVA say, can we continue this? And we could. We had some money left over from the grant, and we got permission to just keep that and apply this to eGlobal as an experience and not as a research study. And that's what we've been doing since that time, and we are now approaching the end of the 4th run of eGlobal. Now, this is very clearly not a research study anymore. We're not collecting any data from the students. It's just a voluntary experience for students at both UVA and UGHE. And, I still continue to be surprised about that this worked, because we cannot offer them anything, right? They don't get any money for it. They don't get any credit for that. We just ask them if they participate to do a certain amount of work, and we have a wait list of people who want to do it. Which is really kind of speaks to how interested people are in doing global health work of some time. This is purely stuff and time that they put in. This didn't always make me feel good. We are asking our students to do stuff, and I think there should be some reward for it. And I'll get back to that in a little while when I finish up. So at UVA, the program is open to any trainee at any level. So most of them are undergraduates, but we do have a fair number of medical and nursing students. We have occasional PhD students who want to participate, and there are rare requests from people in kind of more unclear positions who want to be part of this, and that's fine. If there are spots, we're pretty open to that. In Rwanda at UGHE is mostly now their first year medical students, and they essentially their whole cohort enrolls. I mean, there may be 1 or 2 students who did not want to participate, but basically the whole class wants to be in it, which means that our numbers, how many students can we have, is really kind of limited by how many students UGHE can provide. There's always more students at the UVA side. Now, those students are not as far ahead as medical students as you might expect, because they use the European model where you go into medical school right out of high school. So they're actually age-wise relatively close to our mostly undergraduate students. And then they have a smaller cohort of master students that participate as well. So I'm going to tell you a little bit more about the structure of how the whole thing works. It has changed, it gets tweaked every year a little bit, but the basics have remained the same basically as they were done in the study. So we create what is now about 25 groups of 4 students, 2 from UVA and 2 from UGHE, that'll work together over the year. Then each group picks a research topic, and we ask them, to pick something related to global health. There probably isn't a need to restrict it to that anymore. I'll talk to that in a moment, but that's how it's worked so far. We've created new lists of possible topics every year. So we have a really long one now, and people can recycle topics. There's no reason to revisit the opioid crisis again at this point, building on what the others have done. Occasional groups come with their own ideas, which is great, but that takes some vetting because you want to make sure that's something that can actually be completed within the time frame and what have you. Now, then each group meets an hour per week on Zoom to work jointly on the research part. So they typically wind up doing this on the weekends. Just with time differences, it's hard to find a time that otherwise would work. And then we generally suggest that each individual students put in an additional hour per week to review the literature. We do not require data acquisition beyond what's available on the internet, because it becomes very complicated. They'll need IRB approvals and what have you, and it cannot be supported. There's been occasional requests to do it. There's been some really inventive students who have just interviewed people at the university, for example, which they checked and could do without IRB approval. But basically, it's use the internet and use the databases to find what you need. The program starts in September, run through April, and then at the end, all groups present their finding at a virtual symposium. So this will actually be in a couple of weeks again. It's great fun. Every group has about 10 minutes, and we demand that every student of the force says something. It's sometimes easy for the Rwandan people who don't use English as their first language to kind of stick a little bit in the background and let the UVA students do all the talking. Not allowed. Everyone has to say something. And it's just great to hear what people looked at, what they found, what they came up with over time. We have not asked them again to write up the results in a paper. It was a lot of stress. It comes at a bad time because exams are coming up for both sides, etc. But every year there are a couple of students groups who like to do it and submit it somewhere, and we can help them with that. So there are a couple of other things that are kind of interesting and kind of grew out gradually out of the program. The first is orientation session. So we hold 2 orientation sessions. There's a big general one for the whole group, both Rwanda and the US. And there we talk about the things I'm explaining now. So how do the groups get put together? How do you pick your topic? How do you work through it, etc. But then there's the second one that we do, which is just for the US group and goes about the history and culture of Rwanda. Rwanda has a really complicated and conflicting kind of history that's not interpreted the same way by everyone. And if you want to have an open discussion about the genocide and the aftermath and what came since that time, it's really hard to do when you have 20 Rwanda students present on the Zoom call. So we've typically every year done this in person at UVA with just the US students, and I think it's been a model that's worked well. It does prepare them quite well, I think. At least it helps them to interact with their counterparts in Rwanda, to be appropriately sensitive about the big issues of the country, and to understand when not to ask questions, and etc. We provide a research guide. So this is like a 20-page document that provides examples, helps them to set timelines for when various things should be done. And then in addition, there's always support available through coordinators and directors. So we have one coordinator on each side. On my side here at UVA, it's typically an undergraduate student who does that. We've had people, the current one has been through eGlobal herself and will be running it for the 3rd year this coming time. So highly experienced. And then the Rwanda side, they have a fellow in one of their programs who does the coordination. And then there's still the smaller group of directors, essentially now one on each side who runs it. Like I said, we cannot provide academic credit or payment, but we do provide a certificate from our Center for Global Health here at the university to all students who complete the program. Again, that's something that our UVA students don't care too much about, but for the Rwanda students, it's very important to have an official document from a US university that they participated in this program. For the UVA students, what is important is that we do offer selected opportunities for travel to Rwanda after the program, because this has not shut down, of course, the usual travel programs that happened. So for students who apply for grant funding to travel to Rwanda, it's a big plus if they can say, yes, and I worked with students from Rwanda over the whole past year working on a research project. So that has become something several students wanted to do. And in fact, there have been some pretty emotional meetings when one of our UVA students that way made it to Rwanda and finally got to meet the counterpart from UGHE that they had worked remotely with for a whole year, and finally saw him in person. So that's been really nice. There's no limit how many times students can participate. We've had quite some students work doing it multiple times. I should say we have not in any way so far had some kind of selection process for which students participate. It's essentially first come, first serve, because it just gets too complicated. We maintain a wait list. That wait list goes first the next year, and then we just take people in the order they come. So we've had people. I have one student who's done it 3 times now, and she's just incredibly enthusiastic about it, and she keeps coming back for more. So that's a good sign. The most important thing about eGlobal, and it's something that I have to keep telling students all the time, is the purpose of this program is to have a long-term engagement with students from another country. Okay, that's why we set it up. That's what we want people to get out of it. Why is there this research program that they work on? It's the glue that keeps that engagement together. Okay, it gives them a reason to meet once a week on Zoom and talk. And it's hard for them to remember that and not to start thinking that the research is the primary purpose of the program. It's not. And the same holds for their presentation at the symposium. There are always groups that feel they didn't do enough or that they didn't find enough original new data. It's okay. It's not a problem. Even if they just want to talk about how their experience was, what they did, what they learned from each other, that would be fine with me. I want them to engage once a week as a group with people from another country and learn from them. And so as a result, we've also really encouraged cultural sharing. It doesn't always have to be research. And in fact, we've told people repeatedly that if they wind up spending an hour on Zoom and suddenly realizing they have been talking about their lives and their culture the whole time and never got around to talking about the research project, that's okay. That's not a problem. So we've asked them to think of things like, give your counterparts a virtual tour of the institution where you're working. Walk around with your cell phone and send it out. Or if you're going home, do some introduction to family and friends, etc. All those kind of things are really strongly encouraged. So this is what we've had so far. So we started with 30 students on each side as the research study, so a total of 60. When we started as an experience, we had no idea how this would go, and so we kept it to the same size, although we could have grown. But it worked really well, and we essentially had almost no people drop out, despite the fact that they were, no longer in a study. The study participant, I should have said earlier, did get reimbursed for their participation, so that was a big switch. But with that positive kind of result in 21-22, we upped the number to 92 next year, and then this year we're running close to 100 students. So it's it's grown, and again, it's largely dependent on how many students UGHE has that can participate. And I must say, out of those 100, there's so far be one single student since September who decided he could not participate anymore. Everyone else has stayed in, which I think is really remarkable. I'm very, very happy about this. But the one thing that I was not happy about was that we couldn't really offer them anything else than a certificate at the end. And the other thing was that we were working on leftover grant money, which was not insubstantial, but it was going to run out in probably 5-6 years or something like that. So I've been working mostly trying to find a permanent academic home for this program, because in a way, at UVA, it didn't exist, right? I mean, it was not tied to anything. We had like a virtual kind of home at the Center for Global Health Equity, but it was never eGlobal was never part of a existing program. So I'm really, really happy that about 2 months ago, we managed to make eGlobal an official course at UVA. Now we have a global studies program at the institution, and that is pretty flexible in what they can offer. And so this is a screenshot from their catalog for coming fall, which now has official eGlobal Sustainable Engagement Rwanda as part one, which will be the first semester in there as a course system. So this allows us first to provide credit. It'll be a 2-credit course. There'll be 1 credit for each semester they participate. Second, there's some money available once our grant funding runs out to support it. It's not an expensive program. Most of the cost goes to the course coordinator, who needs to be paid. But mostly this, I hope, will be a way that the program can continue on into the future, and we can maintain it as an official part of the university's offerings instead of just something we were doing on the side. Okay, I think with that I will stop and we can just have an open discussion and questions. Thank you very much, and again, I appreciate all of you being here.